Ben Domenech, I'm a research fellow with the Heartland Institute. I specialize in health policy, and I've been with them now for several years. Before that, I was at HHS and on the Hill, and work in a number of different capacities in addition to that. We have an excellent panel here for you on health policy issues with a number of different perspectives, and I'd like to sort of run through quick introductions for each of our panelists. And then get right into some questions so that we can move along and get to your questions, because I'm sure that there are a multitude of them given the timing of this meeting and given the impending implementation of the President's healthcare law. First, I'd like to introduce Chris Jacobs, who you may recognize from his successful appearance on Who Wants to Be a Millionaire. Chris is with the Heritage Foundation. He's not currently a good bit. You won a good bit. Enough to take some fun trips. Chris is a longtime Hill veteran in terms of his experience on both sides of the Hill, in the Senate and in the House, primarily focused on health policy. He's one of the smartest guys in DC on the subject. He's currently at the Heritage Foundation, where you can read a multitude of interesting things that he writes on their Foundry blog and in a number of other white papers he's put out recently. To his left, David Knox, who is from Arkansas, was a key figure during the course of the back and forth conversation over the expansion of Medicaid in the state, and has an enormous amount of experience within the health policy world. Previously worked at Blue Cross Blue Shield, and has a background along those lines that I think is very good for us to have at the state level in terms of someone who really understands policy issues law. And then we have Jim Frode, who was previously with Speaker Gingrich's Center for Health Transformation, wrote a book with Speaker Gingrich about fraud and other issues, now has his own consultancy and works with a number of different clients within the health sector. Before that was a veteran of, again, Capitol Hill, and worked for a number of different members. So we have a group of very smart people who come at this from a number of different perspectives. But I want to lead off with a question for Chris, because I think this is kind of the issue that Congressman Price just spoke to, that I think is on the mind of a lot of different people right now, given sort of the impending CR fight and everything that comes with that. So tell me why the defund strategy, which is being used right now, is being favored on Capitol Hill by a number of strong conservatives, is not something that is just going to end up putting us in a position where we have a lot of people on the right who get tagged as squishes or squishing out on the issue if they don't want to shut down the government over the issue of defunding.
Well, first off, and I hope you all can hear me, I'd like to thank Ben, thank Heartland for hosting me and bringing me down from Southern hospitality. Greatly appreciate it. And get out in the Heartland, talking with real people outside of Washington. It's always good when you can get outside of Washington. I've spent too much time there already. In terms of defunding, as you may have seen, and as a couple questioners in the last panel alluded to, Heritage does support a defunding strategy. Congress always controls the power of the purse when it comes to Obamacare or anything else for that matter. Defunding has been used in the past historically to defund mandatory spending, entitlement spending. Defunding has been used in the foreign policy realm when Congress wants to make a strong impact on foreign policy or domestic policy. It is a very powerful tool in the congressional arsenal, and we think this is a great opportunity for Congress to do that. That said, when it comes to the strategy, my mother always told me, Christopher, you never know what you can put your mind to until you try. And that's where we're at with this. We now have a month and a half. Congress is on recess, out talking to constituents in their districts. We see more and more stories about the ill effects of Obamacare. Just this morning in the Wall Street Journal, people can't see their doctor. Insurers are closing down networks. People can't see their doctor, can't see their hospitals. So much for if you like your plan, you can keep your plan. If you like your doctor, you can keep your doctor. We're seeing all those ill effects go on. Constant delays, glitches, implementation failures. And so we think this is a great opportunity to have that fight, have that debate, and really drive the conversation in the right direction.
Well, but let me jump in there and just say, I understand what you're saying there, but it seems to me that the problem with this strategy is, and I agree, it's a good conversation, it's a good time to have this conversation. It's good because if we weren't talking about this, we would be talking about how, conservatives hate families because they don't want to endorse universal pre-K or whatever sort of policy the president wants to put out there. But again, Chris, don't you think that this puts us in a position where if we are offered the possibility of delay or something of that nature, as opposed to a full defunding or repeal of anything in particular, do you think that that would still be worth doing? And do you think that the base out there would respond by considering anybody who favors something like that as opposed to full defunding as a squish or someone who isn't living up to conservative principles?
Sure. From a policy perspective, I think the issue with delay is that if you delay the mandates, you delay the entitlements, you still have the regulations potentially going forward, you still have HHS going out there trying to sell the law, you still have all those problems out there. I understand the political dynamic in terms of, only controlling the House and in terms of Republicans and what Harry Reid and Democrats and President Obama might do in the Senate. That said, I don't think any conservative wants to shut down the federal government. And I think conservatives have made that clear. And we might want to have it spending at a little bit lower levels than we have currently, and we can talk about that. But I think conservatives are willing to fund the federal government. We just don't want to fund Obamacare. I understand. I don't want to speak too much for Heritage Action. They're our sister organization, the C4, that goes more into the legislative strategy. But I think people are realistic about the political dynamic. I think the important thing is to really have that debate and not say it's a lost cause or it's hopeless or it's never going to happen before you even go into the fight.
I wouldn't say that when it comes to the shutdown, I'm always reminded of what Jesse Helms said during the 90s, where he commented that every day these buildings are closed, the republic grows stronger, which I think has more truth to it than we might have. Jim, I want to jump to you because I think you are seeing kind of the implementation side of these things in kind of the direct sort of conflicts that are emerging there in terms of how insurers are looking at this. We saw recently that e-health insurance, for example, was going to be brought in to participate in the federal exchange side of things. What are you seeing when it comes to the implementation that Chris talked about?
Well, I think we're 47 days now until October 1st. That's the day the exchanges, state exchanges, and the federal exchange go live. Just today, several attorneys general sent a letter to Secretary Sebelius expressing their concerns over privacy issues. And I can tell you that organized crime all over the world cannot wait until October 1st. I'll give you one little anecdote that's just a tiny snippet of what this will be like. A friend of mine, Stephen Parenti, who's in great fraud research at University of Minnesota, released a paper on the CMS website about a year and a half ago. He said the first day it went up, they had hundreds of hits, almost all from Eastern Europe. Because there's organized crime looking at how to look at latest thinking in our system in order to break in. So there are people, Rumsfeld once talked about the known known, the known unknown, and the unknown unknown. There's an unknown element to the privacy issues and security over your data with this that's going to be potentially very significant. Now, if you ever had your credit score hacked or anything like that, that's embarrassing. If you had your health records compromised, that could be very well be life-changing in personal and professional relationships you have for a lot of reasons. And the amount of data they're collecting, the amount that's going to be available to a lot of people is really, really scary. So that is aside from just the functionality of the website. And whether or not they're going to be helped. Well, the IRS can make the connections to the back end, determine subsidies, the lack of income verification, which is already well known. I think that's going to be a real problem. And one of the first places we're going to see this play out politically is in Virginia, where I live. We have a governor's race in November, and our attorney general is running. He's the Republican. He's been very opposed to Obamacare all along. I think he'll probably get a bit of a tailwind based on his opposition, because he's been so adamant in the last 3.5 years opposed to this. But it'll be very interesting to see. But keep an eye on October 1st. I think it's going to be problematic. And the other part, it rests on getting a bunch of 25-year-old men to buy health insurance. Now, I was an uninsured 25-year-old man, and I can promise you they're not going to buy it. Not to maybe delegitimize myself too much, but my first job out of college was working at a ski resort. and skiing 110 days that winter and jumping off 30-foot cliffs and crazy pictures. I can't believe the things I did. I distinctly remember, this was in the early 90s, we were offered a $50 a month catastrophic health insurance policy. I didn't really know, none of us really knew what that was. But we certainly weren't going to waste $50 of beer money on something like that. So I'm telling you, they're not going to buy it.
So Jim, two stories to sort of go to that point. Number one, a good friend of mine is actually one of the lead consultants with CMS in terms of the testing of the websites when it comes to the fraud side. And his description to me of how far behind they are is measured in more than a year in terms of the kinds of information that they needed to have in order to be testing these sites more than a year ago in terms of their expected time frame that they are only getting now.
And
so,
one quick nugget on that, the state health secretary, Fred Knox from this state, mentioned to me about a week ago, and this is not published anywhere, and so I can't verify it, so you can dismiss this entirely. But he said they've done 30 test runs of carriers trying to ping the federal data hub, and all of them have failed. And they're 47 days out now.
So in another anecdote though, I was out last week in Colorado at the Colorado Health Symposium, sort of the token non-Obamacare fan speaking. And one of the interesting things that I made in my presentation was the case about rate shock, the problems that they're going to have with young people signing up. And in terms of their sort of thumbnail estimates, they need to have about 35% of the exchange be made up of these young and healthy people between 18 and 35. There's some significant problems that they're running into. Number one, the opportunity to stay on your parents' health insurance until 26 is now undercutting them. They would much rather have those people be in the exchanges as opposed to on their parents' plans, so that's coming back to bite them. Number two, in terms of the arguments that they have for people getting coverage, and we'll get to this in a second with David, it's very difficult for them to do outreach in states where the Medicaid expansion has not happened. So there's a lot of people who are sort of in that middle ground, who are in this sort of young and healthy territory that may not qualify for subsidies or would have been in the Medicaid population. That's another difficulty. And finally, when it comes to making the case that you ought to purchase a product that you weren't purchasing before, now that it's actually become more expensive, and keep in mind that for about half of these people, the subsidy is not going to cover up the fact that it's more expensive. That case becomes very difficult. Timothy Jost, one of the biggest cheerleaders for this law, most recently wrote that the reason that young people were going to sign up was because out of a sense of social obligation. You are laughing. I said this to a room of 500 people who supported the law, and they laughed too. Okay? And I'm just going to tell you, I had multiple people come up to me afterwards and say, I supported this law, I support it completely, but my kid's 25, my kid's 26, they're being offered coverage under their employer, and they aren't even signing up for it. So I agree with you completely in terms of your conviction. Now, David, you were in sort of the forefront of the experience in Arkansas, and I would like to hear a little bit about that with the dangled private option, which seemed enticing at first and then became less and less so as we were reminded that Kathleen Sebelius is Kathleen Sebelius. I want you to tell us a little bit about that experience, but then I'd also like to just ask you, going forward in terms of Medicaid, one of the positive sort of theories that there's a handful of positives that come out of Obamacare. One positive I would say is breaking up sort of the employer-sponsored marketplace. There's a potential that could actually be good for us in the long term. But the other silver lining is with the expansion of these Medicaid programs, no state is really going to be able to afford these things in the long term. They're going to have to make reforms, especially after the president or future administrations pull the rug out from underneath them, as Congressman Price said. So tell us a little bit about your experience, and then maybe tell us a little bit about what you see within the Medicaid program as positive reforms that states can be pursuing at this time, even if they're hamstrung by the Fed.
Sure, it's an honor to be just part of the panel and be able to speak to you a little bit about the Arkansas option or the Arkansas private option, as people have said. And when this debate first came up, you either had to expand Medicaid or you did nothing. And a lot of states, actually, I guess most of the states have made that choice. Well, Arkansas, and for those of you legislators, if you didn't expand Medicaid, your hospitals were going to close or they were going to take a big hit. And that was definitely a concern in Arkansas as well, the amount of money that they were going to potentially lose. The rural part of the state, where a lot of the hospitals are already operating on thin margins. And so there was some concern that doing nothing would definitely have a negative effect. But as conservatives, we weren't going to go along with Medicaid expansion. So there was a group that got together, and knowing that there was a third option potentially to do something a little bit different that the Secretary, Kathleen Sebelius, might have given us a waiver for, and that was a private option. And just simply put, it's like giving a person a voucher, instead of having them go into Medicaid, give them a voucher and having them go to the private market and allowing them to purchase health insurance. Okay? So that's kind of the simplistic form of it. But of course, we know there's a whole lot more details, and when you start getting into the details, then red flags start going up left and right, and that's exactly what was going on as we went along. The private option, it was approved. Arkansas is moving forward with it. It did get past the legislature, and we're still finding things out today about it that we don't like. Okay, why? Because it's built on Obamacare. Okay, in order for the private option to work, you have to have the insurance exchanges, because that's how the folks are going to go out and purchase health insurance. So you have to have the insurance exchanges. So all the problems, the privacy issues that we've been dealing with, all of that goes along with the private option. Second part is, yes, even though you're giving folks to take money and purchase it, in order to get the money from the federal government in the first place, we had to expand. Meaning we had to take everybody all the way up to 138%. We couldn't just cut it off at 100 and still get the money. And so we had to expand it to 138. So now we're potentially going to add it. First of all, we're going to only add 250,000. Well, new numbers have come out, and that number has grown over 300,000, and potentially up to 500,000 people will now sign up for the private option.
Just let me interject. What percentage of your population is currently projected to have on Medicaid under the expansion?
Well, when you do Medicaid and private option both, we will have over 1/3 of our state population on government assistance. Because Medicaid, our Medicaid system will not go away, okay? What we're doing is everybody, all the new folks will be signed up for the private, or most of the new folks will be signed up for the private option. All the people who are on disability will continue, under the Medicaid disability, will continue under the Medicaid program. We also have an Our Kids section for coverage of kids, which is about 400-some thousand kids. They will, at the beginning, stay on our Medicaid program, and then eventually, they're also wanting to move all of them over to the private option underneath their parents' insurance for those that fall under that coverage. And so we, again, it looked good because you're taking the voucher program, and we all like vouchers. We all like to give people's choices. We're going to the private market versus the government. But when you really get down to the details, what you're finding out is it's really just another name for government to be able to control people's health decision. And it's something, that again, if it's too good to be true, it probably is. And in our case, it actually is.
So let me interject here. The biggest fight that Heartland has been sort of participating in at the state level over the past 3 years, as you know, is on the exchange on the Medicaid implementation side of things. We've been enormously successful on the exchange side. I think in part because we were able to convince so many folks that this was not in your political best interest to own this. And that if you own it, you will have responsibility for making sure it works. And then you will have to answer for it when it doesn't work. On the Medicaid side, we've run up against essentially the providers, the groups of people who have been arguing that if you are not for expanding Medicaid, that you hate poor people, things of that nature. And unfortunately, they have had some people join in to this argument, which including Republican governors in Michigan in particular, but I would think most egregiously in Ohio, where John Kasich is pushing for a vast expansion of Medicaid and is arguing that the Republicans in the state house, the conservatives who oppose the expansion, do hate poor people, even to the point of saying that he is now going to take this into a ballot issue in order to decide it in a future year because he is so dedicated to the expansion. So David, if you had the ear of John Kasich for a minute and could make an argument to him about what he should do on the Medicaid front, what would you say?
Well, I think it's pretty simple. It's ideas that have already been out there. We need to give power back to the states and just let the states do what they do best, and that's craft a plan that's going to be best for their people. Number one, we've always talked about block grant, global waivers. Basically, give the money back to the states, give them a waiver to do whatever they feel is necessary to take care of their citizens. So that would be the first part of it. And another idea that's already been talked about is catastrophic insurance. One of the things that we kind of found out late in the game was the Oregon study that basically came out and said Medicaid, for all the good that it's supposed to have done, there was really no different health outcomes between those who had Medicaid and those who did not. They said the big difference in that study was in bankruptcies, because of course if you have a huge medical bill and you are poor and you're on Medicaid, you can't pay for it, you have to declare bankruptcy. So one of the ideas that has gone around is to offer catastrophic health insurance. And I guess if I could make one point, and if you forget everything else, remember this one thing, the difference between insurance and benefits. I think that's what we've lost sight about. We want health insurance, but we really are giving people health benefits, and it's costing us hundreds and hundreds of dollars more than what it really needs to be. Just to give you an example, auto insurance, okay? It really only covers if you get into an accident, all right? It doesn't cover changing your oil. It doesn't cover giving you new tires. It doesn't, cover any other breakdowns or anything of that nature. But that's the way we're treating health insurance, is we've got all these other things tacked onto it, all these other mandates, all these other regulations, and it's not really health insurance anymore. I'd like to say it's health benefits. And so we've got to get back to the point of where we're going to offer a safety net to the poorest of poor, give them catastrophic coverage, potentially put a health savings account in there, do some other things that they can do responsibly and work their health insurance the best way, instead of just offering them these benefits that are bankrupting our states and that are costing us more and more each year in our budget.
Jim, did you want to speak to that?
Yeah, I would just say to any state legislator or governor who wants to expand Medicaid, fine, that's a legitimate policy disagreement. But if you're a governor or a state legislator who supports it, you, all your employees, your appointees, and their families should go in that state's Medicaid program.
Yeah.
Actually dropping the coverage you have now
Yeah.
and go, if you believe in it, that's fine, that's legitimate. But you too should go in it to show an example that this is something you put you and your family and your staff in the same program.
To that very point, a great quote, and I think this is just about a direct quote. During the stimulus bill markup back in 2009, I'm pretty sure it was Congressman Deal, then Congressman Deal, offered an amendment because Democrats wanted to let all the unemployed go on Medicaid. And he said, let's have an income cap at $1 million so that, all those fired CEOs couldn't get, free health care from Medicaid. And the classic example of that was the quote from Henry Waxman, who said, it is a theoretical question because I think it is highly unlikely that you are going to find millionaires who would like to go on Medicaid. And this is from Henry Waxman, the congressman who represents Beverly Hills. In other words, none of his constituents want to go on Medicaid. Now, Medicaid, remember, is a quote-unquote free health insurance. No premiums, no co-payments, very little cost sharing. If we can't give it away to millionaires, people who can afford to buy better things, then why are we sticking 60, soon to be 80 million Americans with this health insurance?
So one of the stories that Kaiser Health News recently ran was about the number of people that e-health insurance is sending information right now whose plans are not grandfathered, and who are being told that your high deductible plan is not going to qualify under the cost sharing requirements and the essential benefits under Obamacare. You can't have it anymore. And there are all these people that they're talking about are shocked that they're going to be losing their plan. Jim, tell us a little bit about the experience that you see happening and playing out in the marketplace as people sort of get these notices, many of whom are in their 50s and are having have plans along these lines as an interim before they end up on Medicare, things of that nature.
Normal people, which is nobody in this room, normal people are just about to find out how bad this is for them personally. Now, whenever you're out writing or talking, whatever, testifying, whatever it is you're doing, don't talk in terms of billions and trillions of dollars. Nobody knows what that means. Talk in terms of hundreds and thousands, because that's what families appreciate. A $200 a month policy for a 25-year-old male who's never been to a doctor, they don't get that. Chris mentioned the Wall Street Journal article this morning. Now, this would be a really good thing because this is nowhere else. In your state, one of the ways they're trying to keep premium down the first year roll out of the exchange is exclude all the good providers. So the article this morning said they started in Indiana, so Indiana University, a lot of their providers are excluded. In California, UCLA Medical System, and certainly Cedar-Sinai, where all those stars go, excluded from a lot of the plans on the exchange. So one of the biggest lies ever told was if you like your health insurance, you can keep it. That's clearly false. If you like your doctor, you can keep him or her. Clearly false. Help people understand that. The plans are going to go into in the exchange have different doctor networks and hospital networks. A lot of them are going to be excluded, or their co-pays are going to be a lot higher. The way the bronze, silver, and gold ratios work, most people are going to be paying more to get less. And once normal people, again, you have to tell people about, once normal people understand this, they're going to be really angry. And especially if they have a plan that they like, that's affordable, that's going to go up 2 or 3 times, which is going to happen in a lot of places.
So I want to ask one final question to all 3 of you, and then go to questions from the audience, but I'm sure you all have questions. It seemed to me that there are sort of 3 opportunities to repeal this law, get rid of it, or to fundamentally alter it, what have you. One was at the courts, where we got actually a partial win. Obviously, the Medicaid issue is only existent today. It's only a choice today because of the court case. So that, from my perspective, makes it worth it. At the ballot box, you had a fail, and now you have the opportunity that this could collapse essentially under its own weight. It has to work in order to be popular. It has to actually meet up with these promises. So let me start with you, Chris, and then go to you, Jim. Go to you, David, and then Jim. In terms of how you make the argument about Obamacare as a legislator speaking to your constituent, what would you be telling them in terms of their questions about the opportunities for repeal, what we ought to be doing now, why it's important to keep fighting this issue?
I'll reframe it slightly.
Sure.
I am very concerned about you could call complacency, the idea we just have to stand back, get a bucket of popcorn and watch this thing collapse in front of our eyes. I think there are going to be massive implementation.
You're skeptical of the train wreck. You think it's a partial?
I think it's a partial train wreck. The administration hopes that it can cover over a lot of problems by throwing money at them. I mean, that's the traditional liberal way, is it not? And so there are going to be buckets full of money in cash, if we're not, hopefully not, if we're successful at defunding. But going out the door to try to get people, hooked on this and say it's a great benefit. I think ultimately there is going to come a time when Congress is going to have to reassess this and going to have to reassess all of its health care obligations, because as one of the questioners pointed out, we have $17 trillion in federal debt. It's the old axiom of Stein's law. Unsustainable trends are in the long run unsustainable. At some point in the medium to long term, certainly within our lifetimes, I don't know whether within this presidency or not, there's going to be a reckoning. And when the bond markets say party's over, the party's over. We just don't know when that's going to happen. I do think there are going to be implementation failures. I hope that Congress will stick to its guns and do something good on defunding. And I think there are opportunities to make that case. But the idea that we can just sit back and not proactively make the case and not proactively put forward good solutions and just watch this thing collapse in its own weight, I'm a little worried that is too optimistic a view.
Dave, what do you say to your constituents when they talk to you?
Well, first of all, I let them know is that I want everybody to have access to health care, okay? You heard what Kathleen Spillings has said. I don't want anybody to go out to health care. We just have a philosophical and ideological difference about how we actually get to that point. I would rather churches and other institutions, nonprofit institutions, to be able to have freedom to provide that, through local clinics there. But what I'm finding out is that it's cost too much money, there's too much liability, there's too much government regulations for churches and for other organizations to have those clinics out there. So what we're seeing the government take over of healthcare, and I said that's not the solution to give everybody to healthcare, because as we know in other countries that doesn't work. So first of all, just saying, I agree with you. I want everybody to have access to health care, but it's just a different philosophy on how we get to that actual point. So that definitely is the point that's going to be made. Second of all, I continue to reject any money at all, period, dealing with Obamacare. Okay, I'm not going. If you vote for it, you own it type deal. I'm not going to vote for any funding. I don't care if it's for media. To try to get people the media buys, to try to get people to sign up. To continue setting up the exchanges. I don't care, don't want the money, because as the congressman says, it comes with all these strings attached. And in the states, are going to end up costing for it. So the second thing I would say is don't take any money from the federal government to continue to implement this thing. And then the third thing is develop a plan for your state, because we know that this thing is potentially, not potentially, we know it's going to crack. We know that the end game of this is that it's not going to happen, it's not going to work. And the liberals, they're ready to institute the single payer system. Harry Reid said that recently. Our goal is still a single payer system. So they're not going to care if Obama crashes and burns, because they're going to be ready to implement a single payer system. So we as conservatives have got to be ready, have got to put things in place to do the conservative option. Less government, to try to get rid of some of these regulations, to try to bring freedom through legislation, not just through the employer, but more competition between the states, kind of open things up a little bit. And there's probably a lot of other solutions that we can do, but that's what it's all about, is trying to come up with solutions, because the liberals are going to have their solutions ready when this thing goes down.
I would say personalize it as much as possible and use smaller numbers, not bigger numbers, when talking about this issue with people. When you're in your districts talking to people and they're asking you questions, talk about what this means for them. Talk about how the plan isn't good, it might be more expensive. I mean, as many people have pointed out, Obama promised in 2008 that health insurance premiums would be $2,500 less after his first term. They're $2,500 more. He was off by $5,000. That's a huge, huge misjudgment, massive. It impacts everybody. It impacts employers and hiring. So I would say personalize so people understand it at their level. And keep in mind, too, that with all due respect, when we talk about federalism and 10th Amendment and states, and that's all good, but people vote on how it affects them personally. And remember that. And for some people, maybe Obamacare is a good thing, but for most people, it's not going to be a good thing. It's going to be very expensive. And keep in mind, too, that when they make eligibility determinations for Medicaid, they use modified adjusted gross income. So you're going to have a lot of farmers in your states who make $50,000 a year, who, once they deduct farm equipment, building a new fence and all this, are going to be on Medicaid. You want to see pissed off people? Wait till the farmers, literally with their pitchforks, show up in your office because they're on Medicaid and always thought they were able to live without it. That's going to be people that are very angry. So I would do that calculation and figure out who those people are going to be so you have some sort of response when they show up angry. Ask doctors. This is a great line to use, and feel free to take this. I've used it before. It does work, but try it on your own as well. All the pontificators, just brush them aside. Ask your own doctor what he or she thinks of the Medicaid program. Use that line. And do you want to see more of the middle class on Medicaid? Because Medicaid is the lowest payer in the system. And if you're a 29-year-old setting up practice and you have $300,000 in school debt, you can't take very many Medicaid patients. And there's going to be more and more of the middle class on Medicaid who just doesn't pay. And keep in mind, if you're not a doctor or a nurse or a pharmacist or an actual provider, almost everyone else in the system makes it unnecessarily expensive.
I just want to add one point before we go to your questions, and that's that, in Massachusetts, which obviously, in some ways and not all ways, is the precursor of this law, that we've seen introduced twice now, a requirement that would say that if you are licensed to practice medicine in the state, that you must see Medicaid patients, you must be on Medicaid, which really is going to be the end game, I think, in a lot of states across the country, because doctors simply are going to be in a position where they're being asked to work too much of their time for free, which makes their practices unsustainable. So with that, let me shift over to questions, and thanks. Right here.
Thank you. In Kentucky, our governor, bought into the Unaffordable Care Act and established this exchange. I have met with the individuals that are going to operate the exchange. They anticipate a 45-minute to 1-hour conversation with individuals calling in for application. I think they're wrong. It's going to be longer. But also, when I asked how will you verify their income for these subsidies that are going to be offered, because I think they are very mistaken. I believe that the majority of calls will be, how do I get my free insurance, not how do I pay for it, because they obviously don't want to pay for it, or they can't. And they can't pay the $2,000 fine either, even if we think they can afford it. Now, with that said, I said, okay, so how will you verify? They said, well, if they get in, we will go back later as the data system is created to do so, and we will get those premiums back from them, or those subsidies that they receive. And I said, how are you going to get the $10,000 and $20,000 and $30,000 procedure they received, and they have no money? That's the first part of my question. So I think you all will agree that the database doesn't exist for them to have verification of what these people, this is what I call subprime healthcare. Secondly, it has come to a determination, I understand in another conversation I had with someone else, that some employer groups have realized they can offer what is called a skinny plan. No hospitalization coverage or $100 per day. Thus meaning I think a lot of employees should be furious when they see what their policy is about to turn into so that their employer can continue to offer insurance. Just your comments on both of those, if those are accurate. Thank you.
So real quick, I would just point out that I had an interesting back and forth recently with a liberal journalist about the first aspect of what you said there, particularly because of my skepticism that there is going to be any way that you can claw this back after people are going to have to predict their incomes. And if they're wrong, if they go over, then they're going to have to essentially send that money back, or it's going to have to come out of their tax check, which for a lot of these families at that income level is a huge amount of money. But Jim, do you want to speak to that, and then Chris, maybe the same?
Yeah, well, I'll just say that that's, of course, entirely right. So you have that issue, which how do you verify income for a lot of people who bounce around between jobs, adding jobs, periods of unemployment, whatever it might be. And then the bigger piece, the unknown is the organized crime coming in from all over the world through the internet. And that's going to be something that you may not see right away, but it's going to happen, and it's going to be big. So I would keep that in mind as part of the conversation. But it's going to be a serious problem, and I think watching it unfold is going to be really critical. But again, I would make sure people understand how it affects them personally, and whether or not they're going to be in a plan they don't want, or whether or not their doctor and or their hospital provider that they prefer is in there.
David or Chris?
Yeah, on that one, as far as I know, all the states, regardless of whether you have a state exchange or a federal, and actually Arkansas, we have this kind of hybrid federal-state deal, is whenever they put in the information, it will actually go to a data hub in Virginia. And that data hub is pulling from Social Security, it's pulling, I think, from the IRS database as far as that's concerned. And I think there was one or two other as well that they were all pulling from in order to do that income eligibility. And actually, Arkansas, we passed a statute this time around that says you have to verify income when you go through either the private option or through Medicaid. So we actually passed a piece of legislation that says income has to be verified in order for them to be to sign up. But again, it's going to the federal government. And as he said, there are definitely privacy concerns.
Well, our exchange admitted that the data information is not available for them for another year on all of that verification.
Yeah, and I think there were 16 states or whatever that didn't have to do it. But yeah, that's definitely another critical part of it, is that security of that data and how all that's going to be done. And then, like you said, later on, if they have to get a better job, what all is going to happen on that.
Couple points. First, I think there are going to be, as you alluded to, there are going to be some ticked off people that get sent premium bills in January or February and didn't know when they were told that, sign up for health insurance. What, you mean I have to pay $200 a month for this? And so you could end up seeing waves of ticked off constituents as this thing rolls out. The second point, Gary Cohen, the administration just released this morning, issued $67 million in Navigator grants. Gary Cohen testified, he's the head of all this menagerie at CMS, testified before Congress and said, somebody asked him, what happens if somebody reports to a navigator that they're paid under the table? And there was a long pause, and he said, that's a good question. I'll have to get back to you on that. So the idea that there's going to be accurate, what are the navigators going to do? The third point, to your point on the subsidies, I did a morning bell for Heritage a week or two ago. If somebody has income of $90,000 and they report their income at $35,000, they can get $7,000, $10,000 in extra subsidies. At the end of the year, all they have to pay back is $2,500.
Yes.
So it's in their incentive, in their financial incentive, to lie anyway. Okay, and the fourth point on the skinny plans, it is absolutely right, and what you could also see people doing is dropping dependent coverage. That they will, because the affordability test is based solely on individuals, they don't have to cover spouses or children. And so they'll just say, we'll offer you, the bare minimum coverage for you alone, and the spouses and dependents will not be able to get subsidies on the exchanges, they'll just be out cold.
And one other point too, this Navigator program is going to be a mess. They're just starting their training now. And I'll tell you, it is a jobs program for still unemployed Obama for America people, move on.
That is absolutely true.
Planned
If you
Parenthood.
look where the money is going, who's hiring these people, that's who it is. They're going to be ridiculously unqualified. If I were, some underground filmmaker, I would have just a field day going after these people, asking them questions about health insurance, because they don't know. But the verification issue is such a big one. There's an interesting analogy here, which there's a deeper issue to why they actually don't care all that much about the verification.
Yeah.
In the 80s and 90s, when Microsoft came out with Windows, about half of all Windows used around the world was pirated. Now, Microsoft actually didn't mind that so much because it made it ubiquitous. It was actually a good thing to have some pirating. They were still making tons of money. It's free. It's not really a loss when someone pirates it, especially if they're really poor, but there are more and more people using it. Fraud is actually good if you're on the other side, because you get more people on it, more people addicted, more people using it. So their incentive to stop it is actually pretty limited. Unless it gets really bad and there's major PR problems, which there will be, and then there's some pushback.
One thing you didn't touch on was we are creating a two-tier healthcare system in this country. My doctor is on concierge medicine, and I gladly signed up with him. I think that the money is well worth it. If I have a problem, he calls me back at night. If I have an emergency, I can see him very quickly the same day. I walk in and go, yada, yada. But when in transferring from his regular practice to the concierge, he went from 2,000 patients to 600. So it means that 1,400 patients are out there in the systems. Just interested in your comments on that.
Well, actually, I kind of disagree, only in the sense that I think it's going to be a three-tier system. I think it's going to be Medicaid at the bottom. I think it's going to be exchange, which are going to be Medicaid-like plans in the middle, and then employer plans at the top. Because I think those folks in the middle, the $20,000 to $80,000 range, I think employers are going to figure out over time ways to dump people on the exchanges, whether it's outsourcing, whether it's reorganizing, whether it's getting rid of full-time employees, all that sort of stuff. The concierge medicine, it has upsides and downsides. The flip side of that, though, is that, and I've done some research on this, that some doctors who otherwise would have gotten out of the practice of medicine because of Obamacare, because of these other things, are actually staying in because of concierge medicine, so they can actually be doctors. The Wall Street Journal had an article a couple of weeks ago, the number of doctors that have opted out of Medicare has tripled in the past 4 years. I think that's just a trend that Obamacare is going to exacerbate.
Another question, and I took this again, personalizing it. Ask your doctor if he or she would tell their own children to go into medicine. It is a terrifying question because most doctors will not tell their own kids to go into medicine anymore. Not only, it's always an honorable profession, but the headache, the hassle, the debt, dealing with insurers, dealing with Medicaid, dealing with Medicare. Where are our future doctors going to come from?
Particularly when it comes to primary care.
And speaking of that, I just got a huge report on doctors and what their position is. It was multiple pages, and I'm not sure if you guys got that or not, but I'm happy for that. But first of all, I just want to give you a bit of background of who I am, because I'm very new to the group. This is my first time here. I'm Representative Reinhold from Alaska, and I'm Regular Review Chair. What I'm doing around our state right now is trying to break out and have hearings. What are the impacts to natives? What are the impacts to elderly from Obamacare, to students, to businesses, and break it out so it hits home. So I was at CSG last week, and went to a similar situation like this, and it was pretty much a one-way road. They just told you how it was going to be kind of like civilians in the healthcare breakout. And I asked one of Obama's he has 10 regional directors across the United States, as you will well know, and I believe he was from Region 9. He had announced to us that he was gay, or excuse me, that he had HIV positive, and that he had been denied care. So he really was a zealot to make sure that people were not denied care. So he really had a personal story that people could relate to and embrace his philosophy. But I asked him, I said, you know, we have a $17 trillion debt. We also have approximately 11 million known illegal immigrants. How are those illegal immigrants going to impact us if we really do want to provide care for our own? And all is the answer that he gave back to me we've shown that the undocumented people aren't gonna get care. And that's not true, because they can still go to the hospital, but I thought there was many laws where you couldn't profile people with documented or undocumented. So I guess my question to you is, how is this 11 million, let alone, another 100 million people here, gonna impact Affordable Care Act?
The issue with the law is the law requires you to verify citizenship but not identity. So it says that Chris Jacobs is a citizen, but there's no measures really put in place to say that somebody, that then
I'm not
decides to be Chris Jacobs. And so that is a concern in terms of, people getting access to the exchange and then getting subsidies through that, particularly as Jim talked about with these navigators kind of running amok all over the place, just wanting to sign people up for free healthcare left, right, and center.
In Arkansas, I don't know that it's going to make that much of a difference, because just dealing with the Hispanic community where I'm at, I think it's going to be the same. They're not going to want to sign up. They're not going to want to get on the government rolls because, the fear is that once they're discovered that they're an illegal alien or an undocumented alien, that they're going to get deported or that they're going to get sent back. And so they're, pretty much the cash that takes off the books, they don't fill out anything, they don't pay taxes or anything of that nature. So I mean, really, I think with the Affordable Care Act, I don't think you'll see anything different. I mean, they need health care, they're just going to go to the hospital versus here like they normally do.
You mentioned Indian Health Service, the Native American on the reservation. That's all free, and it's the worst in the country.
Yep. By far. Judson?
Hey, I'm Judson Hill, Georgia. Thanks y'all for being here. Just a different angle on some of the questions. I have two questions. One is, what are states' options for addressing Obamacare? We've heard of don't take it, but right now we all seem to be a lot about don't do this, looking for innovative, common sense, conservative solutions, continue to be, that have been addressed actually before Obamacare came about. And then secondly, kind of a follow-up is, set Obamacare aside a moment, what are some state initiatives that can be done? I'm reading states fighting back on healthcare. What are some real valid, doable state initiatives to address our healthcare challenges? Because if we don't offer a solution, then we're all about knowing that hadn't done us so well in the past time.
I can give you one example that I think it speaks to some of these concerns about primary care, as well as being a positive solution in terms of reducing costs and improving access, and that's scope of practice. We've touched on this a little bit at the Heritage Foundation, but it's certainly something that I've previously worked on. And there actually was another article in the Wall Street Journal today about this, about how some states are trying to reform their scope of practice laws. I know it's very difficult because you have entrenched special interests in the state capitals. My personal view is that a guild is a union by another measure. And so, but you have those people trying to go in there, and I think, healthcare professionals should be able to practice at the top of their license. And so to the extent that we can get some reforms on the state level that deregulate some of that and allow people to practice, I think that will help reduce costs, and I think it will improve access to care, and it's something that we can do in a very kind of pro-market solution.
And I would add one more very, very granular example. Everyone who's a state legislator in here, I hope you all have physician advisory councils of only physicians that you meet with monthly or quarterly, whenever it is, and talk to doctors so they actually know what they're thinking. I would hope that's bare minimum of what you're doing, because they're the people that matter the most. And by the way, their approval ratings are about 4 times yours. So the more times you can get pictured of people in white coats, the better. But if you can get physicians and nurses and others together, keep in mind, access to health insurance is not access to health care. In Canada or on American Indian reservations, it's all free. That doesn't mean you can see a doctor who's any good. It certainly doesn't mean you can see the doctor that you want. It may not guarantee any sort of quality whatsoever. What you actually want to be able to do is see a doctor when you need to see a doctor, or see a nurse when you need to see a nurse. If you had advisory councils in your district, you could help doctors, and there's a lot of doctors, it's not just concierge medicine, it's full-on going gulp, where they're taking only cash. And that's a growing trend. And it's amazing how inexpensive routine care is when you don't have insurers in, you don't have bureaucrats in, you don't have lobbyists in, you don't have all these people in it that are grabbing from the system. You could easily have a network in your state legislature of here are 4 physicians that take cash. Here, it's not that expensive. Now, does that solve everyone's problems? Of course not. But it's providing options, providing direct access to care, which is people want. Access to health insurance is not the same thing as access to healthcare services.
And, well, you know, as far as the states are concerned, it's going to be depending upon your governor and whoever your Medicaid director is. Because in Arkansas, while the Republicans took the legislature for the first time in 138 years, we still had a Democrat governor, and of course, he appointed the Medicaid director. And so we were very, very limited as to what we could actually do. I mean, if you had a conservative governor, conservative, you know, Medicaid director who was willing and open to, you know, I would say the first thing is try to go after, you know, the block grant and global waiver. I don't know if the Obama administration would approve it or not, but hey, let's give it a try and let's see what, you know, see what happens. You know, so that would be the first thing that I would say to do, get control back to your states, and then craft a policy, like I said, either with the catastrophic health plan, if you have to pass legislation in order to allow that to happen, you may need to do that. You know, try to get some of the employment focus off of there and see what you can do to engage the faith-based organizations in your state. So those are just a few.
I have one additional thing, which is sort of a sideline of this. There are remaining legal cases against Obamacare on a number of facets. We'll see whether the one from Oklahoma that's challenging the subsidies, you know, advances. But one of the interesting areas that I think is sort of a sideline issue for you, religious liberty is still an 80-20 issue in the states, in the sense that when you look out at the requirements for religious employers to provide coverage for things that are against their religion, that is an 80-20 polling issue where even people who disagree with them don't believe that they should be forced to require it. And that's the sort of thing where I think, depending on the laws within your state, depending on if you have a mini RFRA or if you have something along those lines, Jennifer Marshall at Heritage is working on model legislation on that front. It would be good, I think, for legislators to put something forward that would help exempt some of these employers with religious opinions, basically saying, yes, you can continue to practice your business without having to compromise your beliefs.
And this is a follow-up just to Chris on the scope of practice, because that's a huge issue.
Mm-hmm.
And are we talking about expanding, allowing APRNs to do more types of services, optometrists to do ophthalmology? Or are we talking about other things? Because that's a huge issue there, and there's a lot of dangling impacts to that.
Yeah,
One clarification.
I mean, I think broadly speaking, to the extent that medical professionals should be able to practice at the highest scope of their license, and that, you know, there are all sorts of battles being fought on all sorts of different state levels surrounding it. But I think broadly, that would expand access to healthcare, potentially reduce costs if you could get people going to a minute clinic, you know, with a nurse practitioner versus a doctor's office for routine care. You know, that expands access and reduces, you know, the cost of that visit. I understand the political dynamic at the state level. I understand that, you know, some of the medical specialty societies or the nurses or whomever, there's a great deal of push-pull there. The Wall Street Journal article talked about California, and, you know, the nurses, you know, are battling different constituency groups there. But I think it is a fight worth having, and I think it's worth talking about. The other one that goes with that, of course, is certificate of need laws, which is somewhat similar in terms of a restriction imposed on the state level to try to open things up to expand access and reduce costs.
We're out of time, so last question.
So your last one.
I just wanted to, I know you're about to wrap up, but, you know, as states consider expanding through this mechanism or through a voucher or any way, I just wanted to kind of wrap up with a quick remark. We had a speaker come in, actually a public policy presentation here in Georgia a couple months ago. It was actually an old advisor to Margaret Thatcher. And when Thatcher ran in 1979 as this great reformer that was going to denationalize industries, one of her campaign mottos was, sort of by necessity, she said that the national health care system is safe with us. That even Thatcher was not willing to attack the national health care system. Because in the words of this advisor, she said that long since had the National Healthcare Service in Britain replaced the Church of England in the hearts and souls of the British people. And that is a reminder to me as we consider this, that, you know, like Jonah Goldberg said, you know, this is, Obamacare is the Machiavellian masterstroke of the middle class. That this is really a fight not about the delivery of health care or practicality of how it's delivered, but it's really a matter of making the middle class functionally dependent on the federal government for the basic sustenance. And it is a changing of the heart of the American people. And when you have advisors who've seen a nation that was once much like ours, that really within our last century made this flip, it's a much bigger question than some of the practicalities that I believe we have an obligation to resist at every corner, because of the hearts and souls of America and what it means to be a free people is really in play. And I just would invite you to close with that. It's been a stark reminder to me, and I just would encourage us to be focused on that.
When Thatcher ran for re-election in 1983, right after the Falklands War, she was the only Tory ever to have Thatcher signs in housing projects all across Britain. Because she was pro-poor, pro-empowerment, sold those off to people. People treat, when they're owners, they're very, very different. The difference between Speaker Hastert from Illinois, when he was Speaker of the House a few years ago, and Nancy Pelosi's district, you know what the biggest difference is between those two? Rates of home ownership in their districts. When you own, you act more responsibly. You look at the entire world differently. But as we wrap up, I know we're running over, I would just say keep your focus more than anything. This debate is about what a single mother does at 3 a.m. when her daughter turns blue. If you don't have an answer for that, all the rest of it doesn't matter.
Just quickly, like Jim, I studied over in England. I have the National Health Service card to prove it. I keep it in my portfolio and look at it occasionally as a reminder, I think, of what we're fighting about and what we're fighting for. I think that's why Senator Benita has been, my boss has been so passionate about defunding. He was on, I think it was Hannity last week, talking about the National Health Service is something like, I think, the third largest employer in the world. Okay. And building that kind of constituency and what it does to a political environment over there. I think that's why we're having this fight, and that's why we want to have this fight in Congress in the fall.
The stakes are high, as you said, and thank you so much for sharing that with us. Thank you so much, everyone.